Universal, affordable, quality healthcare coverage for everybody, bar none.
Single payer.
Socialized medicine.
Universal healthcare system.
That's essentially what Medicare is a single-payer system.
Socialized medicine.
Everybody's got to be covered. This is an un-Republican thing for me to say.
Universal health care.
A single-payer system, the government would buy all the health care.
Socialized medicine. And they say, we don't want government-run health care. We don't want a Canadian-style plan.
Today's goal is to differentiate the terms universal healthcare, single payer, and socialized medicine. But first, let's imagine we're making a healthcare system. The questions we'll need to answer are who's providing healthcare and who's paying for it. The answer to the first question is going to be some mix of public and private providers. On the payer side, we have both public and private payer groups, as well as individuals paying for their own healthcare. While private payers come exclusively in the form of insurance, a public payer could set up an insurance system, or it could just fund healthcare like the military through taxes. Imagine a spectrum. On one end, all healthcare costs are paid by the individual, and on the other, all costs are paid by a single organization, such as the government or a private insurer. What matters here is a global view. Where does the bulk of the responsibility lie for providing and paying for healthcare services? With provider and payer questions as our foundation, let's differentiate these terms. Countries achieve universal healthcare when all citizens have access to acceptable or comprehensive healthcare. The United Nations Sustainable Development Goals highlight the need for financial risk protection and accessible health services. These health services should promote better health through education and measures to prevent illness, like vaccinations, and provide treatment, rehab, and end-of-life care for illnesses. We can assess progress for these services by evaluating and comparing maternal, child, and mental health, the management of infectious and chronic diseases, and the healthcare system's capacity to serve everyone. Because when everyone has access to basic healthcare, this helps reduce the spread of infectious diseases and reduce the severity of chronic diseases. How can countries achieve universal healthcare? Through coordination. As we saw in the last video, uncoordinated healthcare services and obtuse financing are the primary reasons universal healthcare often is not achieved. Uncoordinated systems favor individuals who best navigate the system itself rather than those who want to actually pursue health. But a truly universal healthcare system shouldn't favor anyone. All should have access to comprehensive healthcare. When it becomes pay to play, not only does this widen the gap between the rich and the poor, it conditions us to view healthcare as a commodity, where I want it that way takes precedence over public education and illness prevention. We spend more on healthcare without getting better returns. Does that sound familiar? The extent to which other countries achieve universal healthcare is debatable, but the US certainly does not. Okay, so that's universal healthcare. Single-payer healthcare on this spectrum would be here. The importance of a single payer is its negotiating power. As the payer for millions of people, it gets a group rate. The more payers there are in a healthcare system, the less bargaining power each has. And in the market-based system, this fragmentation allows healthcare providers to raise rates, even if it means pricing some people out. Whether or not a health system is single payer, the fewer payers it does have, the easier it can contain costs. Systems with thousands of payers suffer not only higher prices, but the increased administrative burden of providers interacting with so many different payers. Does that sound familiar? All right, 2 down, 1 to go. Socialized medicine refers to the specific situation where government is both healthcare provider and payer. This healthcare system lends itself to universal healthcare, and it's a form of single payer, but it's not a necessary condition for achieving either. An example of socialized medicine is the Department of Veteran Affairs, which provides and pays for U.S. military veterans healthcare. Several countries have socialized medicine as a benefit of joining the military, which, by the way, is also a socialized service. So here's a bird's eye view of the healthcare systems in similar countries to the US. Something this overview misses, however, is how countries regulate their healthcare services. While the US and Japan are both largely private provider multi-payer systems, Japan requires its private insurance companies to include more comprehensive coverage than the US does. As a result, Japan reaches a greater level of health coverage for all its citizens. Meanwhile, the US is averse to laws regulating private enterprise. In our state of quasi-governmental regulation of health services, many pundits believe it's regulations that are hurting healthcare. In their mind, the best system would be a completely free market with transparent pricing where everyone could decide whether a public health service is worth it. And here's an example of that straight from Facebook. Essentially, the user here wants us to and notice that healthcare prices have skyrocketed since 2000, while TV prices have fallen. The natural conclusion is that services where the government is involved see greater price increases than those that rely on the free market. So yes, this graph does tell us that prices increased, but it doesn't tell us why. The commenter here ignores what we know about free markets in healthcare. They are laden with negative externalities. Negative externalities are a form of free market failure where a transaction between provider and consumer imposes a cost on a non-participating third party. Classic example, pollution. A producer damages the environment and the cost isn't paid by either them or the consumer. Similarly, my health decisions affect more than just my healthcare providers. If I choose not to get vaccinated, that's a cost to other people. So what we're really seeing here is that healthcare doesn't map onto the free market understanding of a transaction between just provider and consumer. And these externalities or unpaid costs add up over time. Eventually, we've got to ask, who's going to pay for this? Are we going to make the producer pay for pollution via regulations? Should we subsidize vaccines?
Are you up to date on your vaccines? Yes.
These aren't questions the producer can answer, and in fact, the producer is going to act in their best interest, going as far to lobby against these regulations. So here would be the more economically sound conclusion from this graph. Many of the services that increase more than inflation are ones that, because of negative externalities, don't map well onto a market-based system. Not to mention, we already subsidize other products here via taxation. Roads that we all pay for via taxes incentivize people to buy cars. To be sure, technological improvements brought about by competition can reduce costs. The problem with this post is that the user wants us to think there is only one conclusion from this graph, and that the conclusion necessarily follows from it.
QED.
What we're converging on here is that healthcare as an atypical market would benefit from a different perspective, one that prices in negative externalities to the provider-patient transaction by allowing third parties to have a stake in it, like taxes. Even if financing healthcare through insurance rather than a tax system, what is insurance other than just a form of taxation? People pay into a pool of money, and then this gets distributed to those in need. Both are redistribution systems designed to protect members from financial ruin. Uwe Reinhardt makes this exact case in Priced Out, saying, due to the clinically and morally compelling nature of healthcare, it operates much like a tax. By clinically compelling, Reinhardt refers to information asymmetry, the complex nature of modern medicine. Healthcare transactions, by their nature, favor providers because of the knowledge gap with patients, despite the patient being the ultimate beneficiary. By morally compelling, Reinhardt means that at some point we should consider healthcare beyond the constraints of economics, healthcare as an end in itself. But if we're insistent on staying with an economic perspective, then we can think of the consumer's demand for healthcare as inelastic. Unlike a rubber band, a patient in need of healthcare can't stretch their options out until they have the money to pay for it. This again puts healthcare transactions favoring providers. Patients will pay high prices to get better. Another aspect important for the healthcare as tax perspective, it isn't a resource needed equally across the population. In the US, about 5% of the population accounts for over half of healthcare spending, while only 3% of healthcare spending comes from half the population. If we leave 5% of the population to coordinate their own healthcare coverage, they will face extremely high costs. Is that fair to them? Did they choose to become sick? Or is health something we should all chip in for? At the end of the day, economics is all about how we ration resources. Price-based rationing means those who value a resource the most will dish the most out for it. Resources then allocate to their most valued actors in a system. By applying this logic to healthcare, we're saying that we think people value healthcare differently. But health is important to all of us. No one person's health is more important than the next. By rationing health by price, we're saying that the rich deserve better healthcare. Which isn't to say that healthcare doesn't get rationed under a tax or insurance-based system. Instead, you get a triage system just like you would see in an emergency department. You don't walk into an emergency department and say, "I've got a broken nose, here's $1,000. You wait, because there are some people bleeding out internally who have a much more dire need for immediate health care. In a non-urgent setting, what we see in other countries that have achieved more universal health systems, preventative healthcare takes the forefront. Instead of going to see a specialist right away, you see your primary, they can refer out if need be. Have these other countries perfected healthcare? No, but they do prioritize a basic level of healthcare for everyone, regardless of their ability to pay. The funny thing is, despite all the conservative fear-mongering about lack of choice in other countries,
Universal healthcare.
many other countries still have private insurance plans allowing the rich to get specialized care. What does
Freedom of choice.
get us in the US? 27 million uninsured and hundreds of thousands of families bankrupted yearly. Conservatives oppose a basic level of healthcare for all, not because of rational economic arguments, but because of a religious faith in the unadulterated free market. In other words, they sacrifice aims towards universal healthcare at the altar of a bastardized freedom meant only for the rich. And this is where we'll be headed next video. A look at the conservative opposition to universal healthcare and their proposed alternatives. And then we'll finally take a look at Uwe Reinhardt's scathing comments about the possibility of universal healthcare in the US. And I will see you then. I like how this graph has like medicine, healthcare, college, housing, like all these important things. And then like debatably like TVs, and then like as a data point, toys.
I got a letter the other day from a woman. She said, "I don't want government-run healthcare. I don't want socialized medicine. And don't touch my Medicare."